So, greetings and a warm welcome to everyone. I'm Srevshi, the assigned moderator from Planet. It is my proud privilege to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce our platform, Planet. It stands as one of the largest live digital CME platforms in India, providing a space for doctors to create and share medical content. So now without any further delay, I would like to invite Dr.AL.Meenakshi Sundaram sir to take over. Sir holds degrees in MBBS, DA, MD Administrator, Dean and DME in Government Medical College, Theni, Chennai, and sir is the Professor of Anesthesiology at Thanjavur and Tirunelveli Medical College, National Vice President of Indian Society of Anesthesiologists, uh, 2016, National Governing Council member of Indian Society of Anesthesiologists, 2009 to 2012, President of ISA, Tamil Nadu State Branch, 2011 to 12, State Secretary of Indian Society of Anesthesiologists, Tamil Nadu State Branch, 2006 to 2010. So, without any much delay, now I would like to hand over the session to you, sir. You can proceed with the talk. Over to you, Dr.
Thank you,
Meenakshi, sir.
Thank you very much. Now I request our City Branch President, Dr. Munian, to offer his presidential address.
Good evening to all. On behalf of ISA City Branch Puthukkottai, I welcome you all. Every week we are conducting online webinar in the name of Puthukkottai Bhudhan. Today we are conducting 11th episode of second edition of Puthukkottai Bhudhan. Our association represents the collective voice of our specialty, dedicated for promoting the highest standard of anesthesia education, like our webinar, the conducting every week, and research. Last week we conducted online webinar on the topic of pediatric anesthesia and acute esophageal fistula. Faculties are from Andhra Medical College, which was attended by 750 delegates. Great thanks to our academic chairman, Dr. A.L.Meenakshi. Today we are going to conduct on the topic of anesthetic management of ENT. There are three subtopics and three speakers are available for lesson. The first topic is by Dr.Arul Pragasam, second year PG student, Kanyakumari Medical College, Nagarjuna, Tamil Nadu. He will speak on the innervation of the larynx. The larynx receives innervation from the vagus nerve. It is a 10th cranial nerve. There are two branches, the superior laryngeal nerve and the recurrent laryngeal nerve. The nerve control the intrinsic laryngeal muscles, which are responsible for regulating the opening and closing of the glottis. Superior laryngeal nerve innervates with the cricothyroid muscles, which is responsible for tensing of the vocal cords. And the recurrent laryngeal nerve innervates the posterior cricoarytenoid muscle, which is responsible for opening of the glottis, as well as the thyroarytenoid lateral cricoarytenoid muscles, which are responsible for the movements of the vocal cords. Understanding the innervation of the larynx is essential for managing various laryngeal disorders and for performing the various surgical procedures on the larynx. Why we should need understanding of the innervation of the larynx? Because the larynx plays a crucial role in its complex functions, including breathing, protecting the airway during swallowing, and modulating the speech. Welcome, Dr. Arul Pragasam. And the second topic is anesthesia for post-tonsillectomy bleeding, which will be presented by Dr. Revathy, consultant anesthesiologist, Dr. Nashik, ENT Hospital and Research Center, Kochi, Kerala. Madam will speak on the post-tonsillectomy bleeding, which will focus on the importance of prompt recognition and management of this potentially life-threatening complication of post-tonsillectomy bleeding, which occurs in about 5% of the total tonsillectomy they are undergoing. The primary bleeding will occur within 24 hours, and the secondary bleeding will occur the 5 to 10 days after post-operative period. The person responsible for post-operative bleeding is increasing age, male sex, and the tonsillectomy for repeated tonsillitis, and sometimes plays surgical techniques. And assessment and management of initial assessment, evaluate the airway, breathing, and circulation, and ask about the signs of bleeding like hematemesis, and hemoptysis, and any bleeding on the nose. And volume resuscitation, administer IV fluids, and reserve adequate blood for transfusion. Bleeding control. Sometimes we can apply packed with adrenaline for controlling the bleeding. If bleeding not controlled, establish the airway. Establish the airway, consider endotracheal intubations. Key points: multidisciplinary approach involving ENT surgeon, anesthetist, emergency department staff are responsible for the effective management of bleeding. Welcome, madam, for your elaborate lectures. And the third topic is anesthesia for the CO2 laser surgery in ENT, which will be presented by Dr. Pankaj Gupta, GC member, ISA National, Nashik, Maharashtra. Anesthesia for laser surgery in ENT requires careful consideration of several factors to ensure patient safety and optimal outcomes. Key challenges: managing hazards from the atmospheric contaminations and laser tissue interactions and endotracheal tube fires. Why CO2 laser are used in ENT surgery? Used in ENT surgery for the precision, minimal thermal damage, and ability to cut, ablation, and coagulation of tissue with minimal bleeding, making them useful for delicate procedure and cancer surgeries in larynx, which also in laryngeal, which also used in laryngeal surgeries, whether it may be a benign or a cancer, nasal surgery, and like polymectomy, and other applications used in the removal of rhinophyma also. Advantage of laser surgery, which will be reduced post-operative periods, fast recovery, and improved access. And the flexible CO2 laser also available to delivery system, allow access to previously difficult area to reach surgery. Anesthetic consideration: assess the potential airway, cardiac status, respiratory status to determine the best anesthesia management strategy. Anesthesia technique: mostly commonly GA, general anesthesia. We are doing laser surgery under general anesthesia. It's focus on maintaining secure airway and preventing and providing adequate analgesia. Ventilation strategy: use ventilation strategy to minimize the barotrauma. Fire prevention we should take adequate measures to prevent endotracheal tube fires, such as the laser resistant endotracheal tube also available. Maintaining a safe distance between laser and endotracheal tubes. Special consideration for CO2 laser surgery. Laser tissue interaction. The CO2 laser infrared radiations is readily absorbed by water, blood, and biological materials, causing thermal injury and vaporization of the cells. Limitations of the CO2 laser. Although it is beneficial to patients, while effective CO2 laser having limitations such as need for a specialist equipment, training, precision for complication, but not done properly. Welcome, sir. Today we gather for online webinar. Our speakers are interested to share their experience. Welcome, sir. Thank you, sir.
Thanks, President. Now I request our Secretary, Dr. Kannan, to give his Secretary report.
Thank you, sir. Good evening to all. I am Dr. Kannan, Secretary, ISA Puthukkottai. Today we are conducting 11th webinar of second edition of Puthukkottai Bhudhan, and I welcome all our eminent speakers to the webinar. Last week, 26 March, we have conducted 10th webinar of second edition of Puthukkottai Bhudhan successfully. Our webinar topic was pediatric anesthesia, especially in tracheoesophageal fistula. We have divided the topic into 3 subtopics. First one is ISTPs and its modifications. Second one is pre-anesthetic assessment of tracheoesophageal fistula. The third one is anesthetic management of tracheoesophageal fistula. Our moderator was Dr. Abranji Koduri, Professor, Andhra Medical College, Visakhapatnam. First subtopic, ISTPs and its modifications, done by Dr. Agila Mumudi. She is postgraduate, Andhra Medical College, Visakhapatnam. She has explained the historical background of ISTPs with original TPS diagram and with the pictures and its measurements very clearly. She has explained functional analysis in spontaneous ventilation and controlled ventilation. She has explained also about Harrison's modifications of ISTPs. She has described 3 types of ISTPs modifications with the diagrams perfectly. She has explained advantages and disadvantages of the T-tubes and very much with different slides. Second subtopic is pre-anesthetic assessment of tracheoesophageal fistula. Any case, we have do the pre-anesthetic assessment of all cases. Pre-anesthetic assessment and pre-anesthetic optimization is very important before we do the case. The topic is done by Dr. Revathy, Assistant Professor, Andhra Medical College, Visakhapatnam. Dr. Revathy has given a complete lecture on tracheoesophageal fistula, not only about anesthesia. She has explained all about tracheoesophageal fistula. She has explained in a very detailed manner of history, incidents and embryology of tracheoesophageal fistula, and classification, associated anomalies, pathophysiology, clinical features, diagnosis, treatment, and pre-anesthetic assessment. Pre-anesthetic assessment includes history, detailed clinical examination, and investigations. And she has explained the optimization of respiratory stresses very well. And the third subtopic is anesthetic management of tracheoesophageal fistula. We all know anesthetic management includes pre-operative, intraoperative, and post-operative. Pre-operative management consists of assessment and optimization. Sorry has explained very well. She has explained the treatment options of tracheoesophageal fistula and pre-operative risk certifications, pre-operative optimization, which includes correction of hypovolemia, correction of hypothermia, correction of electrolyte imbalances, and all. And pre-operative bronchoscopy, anesthetic considerations which we can do, and anesthetic complications, intraoperative management of tracheoesophageal fistula, and post-operative complications and post-operative analgesia. He has explained very well to the topic. And last webinar, 752 delegates has participated. We are expecting 1,000 delegates to participate in the upcoming webinars. And one more thing, we are going to conduct a CME program in May 31st and June 1. Our academic chairman, Dr. Sundaram sir, has come to Puthukkottai last Saturday, that is 29th March. We had a look in the webinar venue. We have inspect all places we have to do in the CME. Thank you, sir. Thank you for your kind cooperation to our ISA Puthukkottai branch. I thank all. Thank you, sir.
Thank you, Secretary sir. And now it is my duty as a thematic address to introduce the faculty to the attending delegates. Now this is the 11th webinar, and we are very happy because this time one PG is from Tamil Nadu, one speaker is from Kerala, another speaker is from Maharashtra, but again moderator is from Kerala. Because when we conducted a spinal anesthesia webinar, the moderator was from Tamil Nadu, PG from Andhra, and another one from Kerala, another one from Maharashtra. So it was a pan-India webinar. Now it is also a pan-India webinar. And today we are happy to have Dr.Arul Pragasam, the youngest, that is the postgraduate in Kanyakumari Medical College, Nagarkoil. When I addressed the first year postgraduates in Kanyakumari, his HOD, Dr. Edward Johnson, I asked him to suggest a postgraduate to be included in the webinar, and he immediately suggested Dr. Arul Pragasam, and he's a nice guy. So he's interested in cricket actually. He's interested in cricket. That means just because he has entered post-graduation, he is yet to achieve his academic feat. So he has left cricket and he has come to anesthesiology. And the best point about him is, for all the attending delegates, he is an eligible bachelor, yet to be married. So we can concentrate how he delivers. So that is a vital point to the many of the people who are attending. and it will be followed by Dr. Revathy Nair. See, this is the first time I am seeing Dr. Revathy in a theatre dress or in a modest dress. Whenever I meet her in Kerala, either in Kochi or in a state conference, see, I'll be wondering, just a cine artist has come over there, and she's a classical dancer actually. So sometimes we will be thinking that she's a heroine, sometimes we will be thinking as a dancer, but never I have imagined as a doctor. That too in the theater attire. I'm very happy. This is the first time I'm seeing her like this. And Madam is a university rank holder. She had the second rank in the university, and she has won the best paper award. That is for saddle block in TURP. She is in Kochi. Sar is also in Kochi, moderator. So she is going to be the would-be jury in Kerala, because she is working in Dr. Naushad ENT hospital, which is a 30-bedded hospital, which is having a cochlear implant program also. So I think this webinar will introduce Dr. Revathy to the great man, Dr. Jerry. Madam, you please follow him, as you are in ENT. He will help you a lot. So a good singer, a dancer, has selected a topic on post-tonsillectomy bleeding. So we are all waiting how he is going to perform, and it will be followed by my dearest friend, Dr. Pankaj Gupta. If we want to introduce Pankaj Gupta, it will be just like one webinar. So I have to devote 45 minutes for him to introduce. But few things I will tell, because once a person has achieved so much, we have to inform everyone. See, he is a national GC member of Indian Society of Anesthesiologists. So he is actively involved in private practitioners forum. That means he is from Nashik. He is involved in private practice for 35 years. See, usually people will occupy the vital posts only through medical colleges. But this man, totally in private practice, he has achieved a feat in national council, means he is such a popular person. He is such a popular person. He has dedicated himself to anesthesia, and from since morning till night, he is working in 3 nursing homes, but a variety of cases he is doing. And his interest is in that ENT anesthesia. That is the reason why he is going to talk about carbon dioxide laser. But he is a IMA Nashik secretary. He is a ISA Nashik secretary. He has won the best secretary award both in IMA and in ISA. He has won the outstanding achievement award by IMA Nashik. These are all routine for him. He will be winning something day by daily. He will be posting that he has won this award. And at one point of time, people will be reluctant to see, because continuously he is winning the awards. That is one thing. But the best part is, everybody should note that he has won the best couple award. That is very, very difficult. See, even Dr. Revathy is wondering how it is possible. Best couple, that too for anesthesiologist. So he has won the best couple award. And another one is, he has organized a chess event in Nashik. And he has brought the grandmasters Abhijit Gunte and Praveen Tipse. Why I remember their names? I am a university chess player. So side by side, I have introduced myself also in this. I have participated twice in All India Interuniversity. So I was following his chess tournaments. So to such a giants are talking, I want a best person to moderate. So immediately I called Dr. Jerry. So he will say just a hi, simple hi, but he will immediately do everything. Last time Sir has participated in our webinar, he has talked about tracheostomy. To be honest, even in my 35 years of anesthesia practice, at that time it was 33 years of anesthesia practice, I have not seen such a photographs in tracheostomy. See how many modes of tracheostomy and the complications he has focused. It is something great. He is a professor of anesthesiology, Amrita Institute of Medical Sciences, Kochi. See, he is living in ENT only. He was introduced by Dr. Lakshmi Kumar from Amrita. So this time also I called, Madam, I want to conduct a ENT webinar. Then she said, oh, you are talking about Dr. Jerry. So it is automatic. It is automatic, Dr. Jerry, but don't think that he is only an anesthesiologist. He has won 100-meter race in school days. Imagine, so if he is a private practitioner, he can run to so many nursing homes, but he is stick to only Amrita Institute of Medical Sciences. So we are running from hospital to hospital like Dr. Pankaj Gupta. So then he has left that. So he tried music. So anesthesiology includes music also, music therapy. So he has tried so many musics, Carnatic, Western, classical, and then he tried Hindustani also. So I think this moderator can now he is learning keyboard, so he can be a musician. Naturally, Dr. Revathy has to dance to her tunes, and they are in ENT only, both the things. So he is a musician in that way also. They have the same vibration. So I think this webinar will be a successful webinar under these 4 faculty. Now I hand over the session to Dr. Jerry, our moderator. Please, sir.
Thank you, sir, for that invitation. I'm audible, right, sir?
Yes, sir.
Yeah. Okay. So, Pankaj sir is much more senior to me, and I probably should not be moderating this session. But thank you anyway for inviting me here, sir. And shall we start with the sessions then straight away? Because for the first talk, we have Dr. Arul Pragasam. He's a postgraduate student, and he's going to talk to us about innovation of the larynx. I don't need to stress the importance of knowing the innovation of the larynx. The simplest thing is that you need to know how to topicalize the airway in case you want to try some sort of a airway intubation or something. In addition, many of the surgeries that we actually give anesthesia to can result in some sort of a nerve injury to the larynx. We need to know what exactly happens and to manage these patients. In addition, when we do instrumentation of the larynx, we can also cause damage. Okay, so over to Arul Pragasam.
Good evening, everyone. Myself is Dr. Arul Pragasam from Kanyakumari Government Medical College. Sir, am I audible, sir?
Yes, you are. Okay.
Yes, sir. Then we will go on to the presentation. Good evening to every my one of our seniors here, and I thank my HOD, Dr. Edward Johnson, and Dr. Meenakshi for providing me the opportunity to present a topic on innovation of larynx in this platform. It is very pleasure to be here to present this topic, and we will move on to the topic. Larynx is a very vital organ which plays a crucial role in breathing, phonation, and airway protection. In the short session, we will explore the sensory and motor supply of the larynx, also the roles of superior laryngeal nerve and recurrent laryngeal nerve, and their anatomical course and significance. By understanding this, we will be helpful in the field of anesthesia in ENT and head and neck surgeries. Larynx is mainly supplied by both sensory and motor innervations. In the subsequent slides, we will see the sensory innervation, then to the motor innervation. First, we will see the sensory innervation. Larynx is mainly supplied by vagus nerve. The 2 branches of the vagus nerve are internal laryngeal nerve and recurrent laryngeal nerve. These are the 2 sensory sensory supply of the larynx which have been supplied. As you can see in this picture, after the larynx came out of the cranial cavity, from the inferior ganglion, the superior laryngeal nerve arises. From where it is divided into internal laryngeal nerve and external laryngeal nerve. We'll see the course of the nerve in the next slide. Here, in this slide, we have seen the sensory supply is by 2 nerves. One is the internal laryngeal nerve, one other is the recurrent laryngeal nerve. In this slide, we can see the course of the vagus nerve and its branches. The vagus, after leaving from the cranial cavity, by passing through the foramen, it is through the middle part of the jugular foramen between the sigmoid and the inferior petrosal sinus, it came out, gives the superior and inferior ganglion. From the inferior ganglion, as the laser is seen, from the inferior ganglion, the nerve arises, which is the superior laryngeal nerve. From the superior laryngeal nerve, it goes down and it gives to 2 branches. That is the internal laryngeal nerve and the external laryngeal nerve. Internal laryngeal nerve, which is purely a sensory nerve, and external laryngeal nerve is purely a motor nerve. Here you can see the internal laryngeal nerve goes and pierces the thyrohyoid membrane. The level of division is at the level of superior curve of II. This landmark is very useful because we are using this for blocking the superior laryngeal nerve. This can be used in case of awake intubation, in case of difficult cases, and to decrease the hemodynamic stress response in case of bronchoscopy surgeries. The internal laryngeal nerve, in this picture, the lateral view you are seeing. The green color one is the thyrohyoid membrane. Superior it is the hyoid cartilage. Here it is inferior blue one is the thyroid cartilage. Between this is the thyrohyoid membrane. The superior laryngeal nerve, after giving these branches, you can see the internal laryngeal nerve goes and pierces this thyrohyoid membrane and go and supply the vocal cord, and also above the vocal cord. Internal laryngeal nerve supplies the mucus of the larynx, which is above the vocal cord, and also the mucous membrane of the pharynx, epiglottis, calicula also supplied by the internal laryngeal nerve. The next nerve is the recurrent laryngeal nerve. The recurrent laryngeal nerve has different pores from the right side and the left side. We'll see why it is different in right and left in the next slide. From the right recurrent laryngeal nerve, you can see it arises from the vagus nerve in the front of the right subclavian artery and winds back below the artery and then upwards behind the subclavian artery and common carotid to reach the tracheoesophageal groove and supply the sensory nerves to the larynx, which is below the vocal cord. Above the vocal cord, it's by the internal laryngeal nerve. Below is by the recurrent laryngeal nerve. The left side, it should be like it is little below. It arises in the thorax, crosses the left of the arch of aorta and loops around the ligamentum arteriosum to reach the tracheoesophageal groove and supplies the sensory nerves to the larynx below the vocal cord. Why it has different pores in right and left side, we will see. During development, the right side and there are 6 aortic arches in right and left side, but in the right side, the 5th and 6th arch will be obliterated. The 4th arch is formed, that is the subclavian artery. So during development, the right recurrent nerve will ascend from the subclavian artery, that is in the root of the neck. But in the left side, the 6th arch is persistent and become the ductus arteriosus. After birth, it is obliterated to become the ligamentum arteriosum. So the nerve is arising at the neck. It's arising in the thorax and arches the arch of aorta. Push back the arch of aorta. So we have different courses in right and left side. Summary of sensory supply of the larynx. The supraglottic part is mainly supplied by the internal branch of the superior laryngeal nerve, as you have seen. Glottic is by both internal and recurrent laryngeal nerve. The subglottic part is mainly by the recurrent laryngeal nerve. Next, we will move to the motor supply of the larynx. Motor innervation of the larynx is mainly by 2 nerves. One is the external laryngeal nerve, other is the recurrent laryngeal nerve. The external laryngeal nerve, as we have seen earlier, it is a branch of superior laryngeal nerve and descend along the walls of the pharynx in company with superior thyroid vessels and penetrate the inferior constrictor muscle and ends by supplying the cricothyroid muscle. This is the thyroid cartilage, this is the cricoid cartilage. Between these two cartilages, the muscle is attached, that is a cricothyroid muscle, and the nerve supplying is the external laryngeal nerve. This is the only muscle of the larynx supplied by the external laryngeal nerve. All the other muscles are supplied by the recurrent laryngeal nerve. The action of this muscle is, the contraction of this muscle will cause thyroid cartilage to move anterior, so the vocal cord will be tense. If there is a paralysis of this external laryngeal nerve, the tension of the vocal cord won't be there, so there will be a hoarseness. So that if the nerve is damaged, high pitch of the voice can be produced. It will be difficult in case of singers. Next, the recurrent laryngeal nerve. The recurrent laryngeal nerve, you have seen the different courses. The nerve passes posterior to the cricothyroid joint. As they enter the larynx, it will become the inferior laryngeal nerve. Inferior laryngeal nerve also gives branches to the inferior constrictor and cricopharyngeus muscle. Here you can see the recurrent laryngeal nerve. After reaching the cricothyroid joint, it became the inferior laryngeal nerve and it became anterior and posterior branches and it supplies all the muscles of the larynx except cricothyroid, we have seen, which is supplied by the external laryngeal nerve. Now we will see the motor supply of the larynx just shortly. The cricothyroid tenses the vocal cord, which is the only muscle which is supplied by the superior laryngeal nerve. All the other muscles are supplied by recurrent laryngeal nerve. The only muscle which abducts the vocal cord is posterior cricoretinoid. We will see the action of the origin and insertion of the muscle, and other muscles lateral cricoretinoid and these muscles added, and the thyroretinoid muscle relaxes the vocal cord. The larynx is seen from the right medial view. These are the two arytenoids, and between these two arytenoid is the transverse arytenoid and oblique arytenoid muscle. This one is the thyroid cartilage. Between the arytenoid and thyroid is the vocalis muscle, and the vocal ligament is attached here. Here you can see the cricoid cartilage here and thyroid cartilage here. Between these two is the arytenoid cartilage is there. Between the cricoid and the muscular process of the arytenoid is the posterior cricoarytenoid. This muscle is only muscle which abducts the. These are the muscles and its actions. The black color arrow mark shows the action of the muscle, while the red color arrow shows the action of the vocal cord. This muscle is the cricothyroid muscle, which is supplied by the superior laryngeal nerve. When the muscle contracts, it pulls the thyroid cartilage anteriorly, so the vocal cord stretches. It tenses the vocal cord. When the nerve or the muscle is damaged, the tension of the vocal cord is lost, so the hoarseness will be there. This muscle is the thyroarytenoid muscle. When the muscle contracts, it pulls the arytenoid anteriorly, so the length between the thyroid and the arytenoid cartilage will be low, and the vocal cord is relaxed here. And this muscle is the posterior cricoarytenoid, important muscle which abducts the vocal cord, only muscle which abducts the vocal cord. Here, this is the cricoid cartilage from superior view, and this is the arytenoid cartilage where the muscular process is attached. When the muscle pulls, this muscular process will comes posteriorly, so this will go laterally, which results in abduction of the vocal cord. Only muscle which results in abduction of vocal cord is posterior cricoarytenoid. This is a cricoarytenoid muscle. When it contracts, the muscular process will go anteriorly, so there will be a tension of the vocal cord, and these two muscles will cause adduction of the vocal cord. This is a small video. Will show the action of posterior cricoarytenoid and cricothyroid muscle. Contract, it pulls the thyroid anteriorly, resulting in tension of the vocal cord. Okay, thank you. I hope this presentation provides valuable insights on clinical significance and laryngeal innervation.
Sir, I think he is having some net problem. So he has covered it. We can go to the next speaker.
I think we'll go on to the next speaker.
Yeah,
Yes.
there is a problem with the net.
Okay. Next speaker is Dr. Revathy. She's going to talk about post-tonsillectomy bleed. Okay, a very important topic. Maybe an uncommon one right now, but then one of the most scariest things in the past. Okay, so an important question for the postgraduate student. Over to Dr. Revathy, please.
Hello, I think Dr. Arul is still sharing his screen, so I am not able to share my screen.
Yes, he has to. Dr. Arul.
You can share.
Yeah, yes. Hi. Shall we proceed?
Yeah, please do.
Good evening, everyone. Thank you, sir, for such a wonderful introduction, and thank you for inviting me for this prestigious academic extravaganza. So let's speak about post-tonsillectomy bleeding. Imagine you have been called to see a 5-year-old child who had tonsillectomy 6 hours previously. The child is bleeding and needs to go back to theater for hemostasis. When you arrive at the ward, the child is agitated and says he feels sick. The postoperative blood loss is reported to be minimal by the nursing staff. On examination, he is pale, pulse rate is 125 per minute, respiratory rate 25, blood pressure 80/40, and capillary refill more than 4 seconds. What are the specific problems in this case? How will you assess hypovolemia in a child? what is the immediate management in the ward? And I hope at the end of this presentation, everyone will be able to answer these questions. Post-tonsillectomy hemorrhage is considered to be the most common complication following tonsillectomy, and the incidence is reported to be about 0.5 to 3%. The post-tonsillectomy hemorrhage is classified into primary, which happens during the surgery, reactionary that occurs within 24 hours, and it can be due to slippage of ligature, dislodgement of clots due to retching or vomiting, and secondary that occurs from 24 hours to several days with maximum incidence between 5 to 10 days post-surgery. It is usually associated with a secondary infection and sloughing of the scar overlying the tonsillar bed. Coming to the basics, the blood supply of tonsil is through the external carotid artery and its branches. Superior pole is supplied by the ascending pharyngeal artery and the lesser palatine artery. Inferior pole by facial arteries branches, dorsal lingual artery, and the ascending palatine artery. Venous return is to the plexus around the tonsillar capsule, the lingual vein, and the pharyngeal plexus. And thankfully, post-tonsillectomy bleeding is usually venous in origin. It is a slow bleeding. The risk factors for post-tonsillectomy bleeding are: it increases with age, with a more common incidence more than 5 years old. It's more in male population. The surgical technique, which I will describe, and the surgeon inexperience for a primary bleeding, and undetected coagulopathy in very uncommon situations. Regarding the surgical technique, the conventional or the cold steel technique has got more intraoperative bleeding, whereas the hot techniques that which we use more commonly nowadays, including the electrocautery and coblation, has got more incidence of post-operative bleeding. The use of tranexamic acid is controversial. The systematic review and meta-analysis suggests that tranexamic acid may reduce the amount of blood loss during tonsillectomy, but not the incidence of post-operative hemorrhage. So what are the anesthetic considerations in this patient? One and important is potential hypovolemia. Second is pulmonary aspiration of either the regurgitated swallowed blood or post-operative food intake. Potential difficult intubation, either due to bleeding obscuring the view, edema from previous airway instrumentation, and the formed clots obstructing the airway. A second, general anesthesia and the effect of residual narcotics. A shared airway between the surgeon causing obstruction of the endotracheal tube by the mouth gag, and management of an anxious child and his parent. Regarding the preoperative assessment, the presenting signs relate to the quantity of blood loss. But it's usually difficult to measure the blood loss as the bleeding may occur over several hours and large amounts of blood may be swallowed. The child may be hypovolemic with a low hematocrit. The early indicators include tachycardia, tachypnea, delayed capillary refill, and decreased urine output. Where the late signs are hypotension, altered sensorium, and metabolic acidosis. Tachycardia can be due to anxiety or hypovolemia, where bradycardia is due to acidosis and hypoxia is a pre-terminal sign. Prolonged capillary refill more than 2 seconds, mottling, pallor, or peripheral cyanosis are indicators of poor skin perfusion. Blood pressure is usually difficult to measure, especially in younger children, and hypotension is a late sign of hypovolemic shock. Tachypnea can be again due to anxiety or acidosis, and also with severe anemia. Look for decreased or absent urine output, and blood gas analysis may reveal a metabolic acidosis secondary to poor tissue perfusion. Preoperative resuscitation is essential and should be guided by clinical signs and the monitoring. The child must be resuscitated before induction of anesthesia to avoid cardiovascular collapse. Secure a large bore IV cannula, and if it's difficult, use an ultrasound or use an intraosseous route. Send for complete blood count and coagulation variables. Arrange blood and blood products, and if possible, apply a simple face mask and oxygenate the child. Resuscitation should be started with isotonic crystalloid at a dose of 10 to 20 ml per kg bolus over 5 to 20 minutes and repeated if necessary after reassessment of the cardiovascular system. Sometimes it may require large volumes of fluid, about 40 to 60 ml, and avoid hypotonic fluids like dextrose or half normal saline. Look at the chart and note the time since surgery. Usually, children are encouraged to eat post-operatively. Usually, they'll be fed with buckets of ice cream, and note the time since the last ingestion of food. Look for the presence of clots in the mouth in sitting position if possible, and any signs of airway difficulty or obstruction, such as stridor or intercostal or tracheal recession. Examine the previous anesthesia chart if available to identify the size of the tracheal tube that is used, the analgesia administered, and also any problems such as intubation difficulty. Analgesia administered during the first operation must be taken into account if you are planning to give a second dose of opioid. Avoid preoperative sedation, give anti-aspiration prophylaxis, give an anti-CLFO, and give dexamethasone 0.1 milligram per kilogram. It helps to reduce airway edema and also has a role in anti-emesis. If available, ask for a senior help. And prepare your OT with at least 2 suction devices with widebore tubing. Use Angur suction. It should be turned on and available for immediate use. Laryngoscopes with correct size of blade. Check they are working and ready for use. Tracheal tube, if it's a late hemorrhage, the size that can be used as previously, or generally we use a size smaller than that of the previous used. 2 tubes of each size should be kept ready because the first tube may get obstructed with blood clots. Widebore nasogastric and or orogastric tubes to empty the stomach. Emergency drugs, and call the surgeon and surgical assistant should be scrubbed in and ready with all their instruments. Regarding the anesthesia technique, there is some debate about the safest technique of anesthesia for a bleeding tonsil. The 2 common choices are rapid sequence IV induction with cricoid pressure, and second is inhalation induction in the head-down lateral position. Coming to inhalation induction, the advantages said are oxygenation is well maintained during spontaneous ventilation. The lateral position helps to drain the blood from airway and clots can be suctioned. And it will be useful in a previously difficult airway as the spontaneous ventilation is maintained. But the disadvantages are inhalation induction in an anxious child who's bleeding in a lateral position is initially itself is difficult position, and inhalation induction is slow. So again, there is chance of aspiration. If there is deep anesthesia, it can cause a cardiac arrest in a child who may still be hypovolemic, and particularly in the earlier days where halothane was used. Intubating in the lateral position is unfamiliar to most anesthesiologists, and many would turn the child into supine position prior to intubation. So, rapid sequence induction and intubation is usually advised. The advantages are anesthesia can be induced in the supine position with the application of cricoid pressure to reduce the risk of aspiration. The use of muscle relaxant helps to produce an ideal condition for intubation. And IV induction is less stressful for the child who already have an IV cannula. The classical technique, we pre-oxygenate the child with 100% oxygen. Position the child in head-down tilt with the lateral position if the child tolerates. A judicious dose of induction agent should be given, not the higher amount, because there may be hemodynamic compromise and there can be the vasodilatation induced by propofol may cause a sudden cardiovascular collapse. So use a judicious dose, and the assistant apply cricoid pressure. And we know that applying cricoid pressure is again controversial, especially in a pediatric patient. Give rapid onset muscle relaxant, succinylcholine or rocuronium. Perform laryngoscopy and give a quick suction. Intubate with the cuffed endotracheal tube, usually a oral RIE, one size smaller. And if the tube gets blocked, give a tube suction if possible, or change the tube. Recheck the vitals and continue fluids. Allow the surgeon to proceed as soon as possible. Transient hypoxemia was the most common adverse effect that is reported with rapid sequence induction and intubation. So, some may recommend a modified rapid sequence induction intubation in cases of slow venous bleeding, where without cricoid pressure, a gentle controlled ventilation with pressure less than 12 centimeters of water, and laryngoscopy when a deep plane of anesthesia and profound paralysis been achieved. The disadvantages with rapid sequence induction intubation is that, again, pre-oxygenation in a bleeding child might be difficult. Face mask ventilation, even with smaller pressure, can cause stomach inflation and cause regurgitation and aspiration. Risk of hypoxia if intubation is difficult in a paralyzed patient. Regarding the maintenance, during the operation, further fluid and blood should be given as guided by the clinical monitoring. The child may become cold during surgery due to large volume transfusion. The child should be kept well covered to maintain body temperature. A warming blanket used with temperature monitoring, and hypothermia can exacerbate the coagulopathy if there is one. Usually, post-tonsillectomy hemorrhage procedure is a short surgical case. So use short-acting agents and prepare for an early emergence. Multimodal analgesia using smaller doses of opioid and acetaminophen. Once hemostasis is achieved, use a large bore gastric tube should pass and under direct vision to empty the stomach. Reverse your muscle relaxant and the trachea should be extubated with the child fully awake, having a stable hemodynamics in the lateral head-down position. And in the postoperative area, keep the child in tonsil position. The postoperatively, it is important to monitor the child in a closely well-lit area. Do not return them to a dark ward at night. Monitor vitals and give blood transfusion according to hematocrit. Analgesia using paracetamol, NSAIDs, or small doses of opioids. They should remain in the hospital for at least 24 hours after surgery. Discharge from hospital is planned when there is no further signs of bleeding. They have no further transfusion requirements. They have resumed normal eating and drinking, and their pain is well controlled. So let's try to answer our initial questions. What are the specific problems? One is hypovolemia, second aspiration, potential difficult intubation, the need of second general anesthesia, management of an anxious child and parents. How will we assess hypovolemia? Look at the cardiovascular system, tachycardia, low blood pressure, or prolonged capillary refill. A cold, motile skin, cerebral signs like agitation, confusion, drowsiness, or depressed consciousness level. Look for low or absent urine output, tachypnea and acidotic breathing. And look for lab values like low hemoglobin, metabolic acidosis with or without compensatory respiratory alkalosis, and a high blood lactate. What is the immediate management? The aim of the management is to treat the hypovolemia without delaying transfer to theater for hemostasis. It's important to optimize the child before a general anesthesia to avoid cardiovascular collapse during induction. Assess for respiratory distress, assess the volume status, obtain intravenous access, send for a blood count, cross-match and coagulation, resuscitate with IV fluid and blood products if necessary, prepare your theater before shifting the patient. These are my references and thank you.
Thank you, Dr. Revathy. I just have one question. What is the fluid that you would generally use for resuscitation? I just want to know.
I use finger lactate, sir.
Finger lactate, right. But you mentioned something about half normal saline. I was just wondering what it was.
Never use half normal saline.
Okay, fine, right. Thank you. Well, right. Shall we go on to the next talk, sir?
Yes, sir. It is only moderator's game.
All right. So our next speaker is Dr. Pankaj Gupta. Now he's going to talk to us about anesthesia for CO2 laser surgeries in ENT. Now you know that the laser surgeries are becoming more common in the ENT setup, and all the more important that we should know the various considerations that comes with it. So over to Dr. Pankaj Gupta. Sir, please.
Thank you, Dr. Jerry, sir.
Yeah.
And it's always good to communicate with people from other parts of the country, because what I may be doing in Nashik, Maharashtra, maybe the practice may be a little different in your state, especially when in such highly specialized surgeries like ENT laser. Believe me, I've been in practice for 35 years, and I made it a point to try to work with only specialized surgeries. I do a lot of neonatal and pediatric anesthesia. I do a lot of laparoscopy anesthesia. I do a lot of joint replacement anesthesia, and of course ENT, which I feel is very challenging in many times, especially when you're doing a lot of laser surgeries. Thank you, Dr. Meenakshi Sundaram, for that introduction. And always a pleasure to communicate with the Puthukkottai branch, which I feel every year they've been having these sort of sessions. And I feel obliged that I could contribute in my small way. I bring you greetings from the ISS Square in Nashik. If you are in Nashik, please do visit this monument, one of its kind probably in the world. I will try to cover the types of lasers in airway surgery, the pre-op assessment, the preparation and induction, the airway management and ventilation options that we have, the hazards of laser and how to prevent them, and of course crisis management in case of unfortunate airway fires, which are occasionally seen. A laser is basically light amplification by stimulated emission of radiation. It is a device that produces and amplifies light by stimulated emission of radiation. It can produce light in the ultraviolet, visible, and infrared region of the electromagnetic spectrum. And the basic ability of any laser machine to transfer large quantities of energy rapidly and precisely to remote locations, achieved with the use of coherent, collimator, and monochromatic light, focused with the use of resonating mirrors or fiber optic bundles, is what laser is all about. Basically, the laser power density is the amount of power distributed within an area and is indicated in watts per square centimeters. From our point of view, we should know that what a laser beam does is basically intense light beams are focused with intense energy to very small target sites, and they become very popular, especially in any intraoral surgery, because it is very difficult to use the regular scalpel to take an incision in the oral cavity. And I feel wherever there is mucosa, I feel laser does a wonderful job. Various types of laser, they have been discussed in one of the previous lectures. I will restrict my talk to basically carbon dioxide, where it has a very low coagulation effect, but a very high cutting effect. So that's why CO2 lasers have become very common in, especially in ENT surgery. So lasers, the CO2 laser can be used as a scalpel, electrocoagulator, wherever there is precise microsurgery, or you want a very dry field with less damage to adjunct tissue, with less postoperative edema and pain. I feel it straight away, as anesthesiologist, the first thing that comes to our mind is any laryngeal surgeries. What happens when laser strikes the tissue? There are temperature changes, which there is reduction of enzyme activity at about 50 degrees centigrade. At 100 degrees centigrade, explosive vaporization starts, and this cell begins to explode. And gradually, at about 400 to 500, there are chars. So we have to know that the temperatures are very high where the laser beam strikes. The other lasers, I feel the Nd:YAG laser is also available, but it is more common for surgeries distal to the larynx. The KTP laser machine is also there, which again is more common for distal to larynx. And the diet laser has been used for hyperplastic nasal turbinate reduction. It has a flexible fiber beam and has been used more with dentists I have seen for debulking airway tumors. This is the machine that is, as I said, the CO2 laser is a high cutting beam with lesser coagulation. It is used in majority of intraoral and airway procedures, except where coagulation of large vessels is the problem. Because the CO2 laser can seal blood vessels which are less than 0.5 mm in diameter. Carbon dioxide is mixed with nitrogen and helium as its medium, because basically carbon dioxide laser is an invisible beam. So you do require another laser incorporated into the CO2 laser, which acts like a pointer. So that's why the equipment required is you require an operating microscope, you require a pointer, you require a joystick. And one very important aspect of carbon dioxide, it is highly water absorbent. So this technique, this has made it easier for us to improve the safety profiles by using water as much as possible wherever we can. One important thing is it preserves the adjacent tissues. So rapid healing with minimal scarring and reduced pain is one of the hallmarks of carbon dioxide laser. I've done a lot of laryngeal surgeries, and believe me, the glottic competency is hardly ever jeopardized in any way. These are all the surgeries where I have seen it being performed over the years. The papillomas, the laryngeal polyps, the nodules, the neoformations, Rinke's edema, the laryngitis, granulomas, congenital webs, any dysplastic conditions, leukoplakias, erythroplasia, primary laryngeal tumors for stage 1, stage 2 can easily be operated just using the laser. If there is a radiotherapy failure, then laser does come in. And of course, if you have a paralyzed vocal cords, we had a wonderful discussion at the beginning. If you have a paralyzed vocal cord, you can usually use laser to do specific surgeries and see that the airway patency is maintained. Laryngeotracheal stenosis and laryngeal amyloidosis, there are other surgeries which can be done. Basically, any surgery on the oropharynx, pharynx, the nose or tracheobronchial tree can easily be done with the CO2 laser. This is what the setup basically is, and this is how you see through the visualizing endoscope of the surgeon. In any laser surgery, I feel the pre-op assessment and optimization is most important. A proper detailed history, whether the patient is having any difficulty in breathing, difficulty in lying down, swallowing, snoring, stridor, wheezing, whether he has a difficulty in clearing secretions, whether he has had any change in voice. The best breathing position is important to know, because some patients are very comfortable in the lateral position of post-surgery, and also their breathing pattern during sleep. Always apprehend the location, size, extent, mobility of the lesion in the extent of the airway compromise that the patient may have had. Patients who are already cardiac and respiratory systems compromised can be more challenging for these type of surgeries. Obesity, a history of acid reflux and hiatus hernia, again increases the risk of aspiration. We have to be very careful as anesthesiologists in managing these patients. Always assess the airway. A direct or indirect laryngoscope is a must. A chest X-ray, CT scan or MRI of the lesion if required. Always try to assess the airflow obstruction, which can occur even post-induction, and also the site of the lesion, whether it is supraglottic, glottic, or subglottic. Monitoring, along with the routine monitoring, I feel monitoring the airway pressure is also important, and some compromised patients definitely require invasive monitoring. In the pre-op preparation, always try to allay the anxiety of the patient. Sedatives are very much avoided unless the patient is really very apprehensive. Then a mild sedation can be thought of, because many times you just give sedation, and if the patient is having a airway tumor, the airway just collapses in front of you and you can't do anything about it. Always keep a difficult airway card ready. A rigid bronchoscope, a jet ventilator, and tracheostomy tray is always standby in all these intraoral surgeries. One important thing of suspension laryngoscopy, which is done to get proper access to the larynx, is the hypertensive response. As anesthesiologists, we have to be very careful that the patient has very good balanced anesthesia. And if the patient is a known hypertensive, always give some preoperative antihypertensive on the morning of the surgery. Keep some antihypertensive ready during the surgery. Small doses of esmolol or any beta blocker definitely help a long way in keeping the blood pressure maintained during the surgery. Believe me, with this suspension laryngoscopy, the blood pressure can really shoot up to any astronomical level. So you have to be very, very careful in maintaining the blood pressure. During anesthesia, we can use intubating anesthesia, which is most common because obviously you're protecting the trachea, and of course, special tubes are required. There are some apneic techniques which I'll discuss, and tubeless anesthesia. There was a patient in the chat box, I'll definitely mention about it. The most important thing for me is adequate depth of balanced anesthesia. The ventilation can be with intubation. You see that you have proper tubes, or you can even wrap the endotracheal tubes, which we used to do in the initial stages of our practice. There are a lot of non-intubation techniques, like the intermittent apnea, the spontaneous ventilation, the insufflation, the jet ventilation. All this can be done for this type of surgeries. For very small growths, a small routine intubation after induction with a small size tube, the special tube that I mentioned. For moderate groups, some people prefer awake intubation, or straight away go ahead with a tracheostomy if the tumor is very large or can be a threat for the vocal cords. For very large growths, prefer a tracheostomy electively without any sedation, because some such cases can be very, very disastrous on table. If you have an intubated patient, we are all used to it, so it's good for us. The airway is protected, the ventilation is well controlled, depth of anesthesia can be well monitored, and we can monitor the ATCO2. The disadvantage is it limits the surgical access and the visibility of some tumors. The airway pressures may be high because invariably we have to use a smaller size endotracheal tube. The higher resistance and also the suctioning can be difficult at some times. Occasionally, these tubes can kink and can get occluded, but of course not the present day metallic tubes that we use. And of course, the risk of airway fire always has to be maintained, has to be thought of when you have intubated a patient. Spontaneous ventilation, you will only think of a very small lesions, and I will not advocate it because there's always a chance of risk of aspiration, and the surgical field is not immobile. So if a surgeon finds it a little difficult to operate when the patient is spontaneously ventilating, but it's mentioned, so I just wanted to mention something about it. Insufflation techniques can be thought of now because we have high frequency ventilation. And of course, the disadvantage is we have no control over the ventilation. Again, the risk of aspiration can be gastric distension, the O2 can be polluted, and the depth of anesthesia can be inconsistent. Intermittent apnea, you can induce the patient with endotracheal tube insertion, ventilate till the patient is 100% saturated. Remove the tube and the surgeon takes over the procedure through the suspension laryngoscope and the aiming the larynx. He can operate on it. But the first time when I did it, it was quite a nightmare because I was not used to it. And now that I'm used to it, it can be quite safely done. The advantage is it gives an excellent visibility of the field and safety, because when you're doing this procedure, always see that you have a regular tube also as standby, and occasionally you may have to pass in the tube and ventilate the patient to bring back the saturation to 100%. Of course, you don't do it in patients who are really compromised with the cardiorespiratory system. This is how it is done. There's a small video I have, which I don't mind sharing with you. This was a case of laryngeal papillomatosis. We had removed all the papillomatosis which were supralaryngeal, but there were a lot of papillomatosis which were a little in the glottis or in the subglottic area. So what we had to do was, for those who are not used to this type of surgery, this is a metallic tube which is there. This is called a malingdotted tube, which we regularly use. And once the tube is removed, you will realize that the surgeon is aiming the laryngeal beam. Now the tube has been removed. You will see a red dot, which is signifying the laser beam being pointed towards the papillomas. I hope you can visualize the concept of the papillomas which are there. These are subglottic papillomatosis. The surgeon is doing a suction. They ventilated the patient to 100% oxygen. You can see a little bit of the papillomas, and now you can see a red beam striking the papillomas and how they are being burned by the ETCO2 laser. So this is how the whole surgery is done. The first time, as I said, even I was a little worried because we are not used to having the airway exposed in front of us. But it's quite safe as long as you are confident enough in managing these patients. This type of surgeries we have come across quite often. I mean, this is just like a question to everyone: will you intubate? I've had a experience with a similar laryngeal tumor where we intubated the patient, and at the end of it, when I tried ventilating, I could just not ventilate the patient, and we didn't realize that the tumor was very much pedunculated, and along with the tube had gone anteriorly. So we had the presence of mind to remove the tube and immediately change the tube, and we realized that the tumor had got, I mean, as an anesthesiologist, I had removed the tumor, and we had to do a coagulation of the field. So it is very important when you're doing laryngeal tumors. Jet ventilation, I thought I'll just, because we all know what jet ventilation is, that gas under high pressure is supplied via a 16G catheter, which is aligned with the laryngoscope, which may be open to the ambient air. Always important to monitor the chest wall motions for adequate inspiration and expiration. The jet ventilation can be done supraglottic or subglottic. And there's always a chance of pulmonary barotrauma, so we have to be careful about it. With this, many times the patient has to be maintained on intravenous anesthesia, because you can't anesthesia gases through the jet. So the risk of debris or blood or tissues blowing distally is always there with this. High frequency jet ventilation, as I said, now can be routinely used. Again, as long as you're maintaining the anesthesia with TIVA. Problems with jet ventilation can be very high, especially the patient is very obese or COPD or restrictive lung diseases. We cannot monitor the ATCO2. And of course, post-op laryngospasm or laryngeal edema or a stridor or pneumothorax can easily occur. Some of the laser hazards and precautions that we have to take as anesthesiologists. Laser plumes is one of the most danger things that even the OT atmosphere can get contaminated. There can be occasional perforation of vessels. Airway fire is one of the worst complications that we dread. Air embolism has been known with distal to laryngeal surgeries. There may be inappropriate energy transfer to either the drape or to the surrounding tissues. There can be damage to the eye, cornea, skin, or mucosa, or even to the endotracheal tubes if not taken proper precautions, and the drapes can catch fire. So with laser surgery, you always have to protect yourself as much as possible, including your eyes. Laser plumes. Basically, there is the laser beam hitting the tissue give rise to fine particulate matter, which may be even 0.3 microns. And this can get deposited in the alveoli of not just the patient, but even the OT atmosphere can get contaminated. So that is why it is very important that a smoke evacuator or there are always two suction machines which are used in the suspension laryngoscope. So all these plumes go directly into the suction machine, and preferably the OT atmosphere is not polluted. You have to be very careful. In minor surgeries, there is no problem. But if for very major surgery, when a laser is being used for to real dissect larger tissues, you have to be very careful of OT contamination. Perforation of vessels can occur. Occasional pneumothorax also has been reported. There's also ocular injury to cornea. Airway fire is one of the worst. There was a beautiful discussion in the previous lecture also. These are some tubes which have been hit by laser, and you can see what has happened to them. So just imagine if you have a patient with the tube inside and the laser has hit the tube, or there is an airway fire, what will happen to the airway? Laser surgery there is a triad for fire because there are inflammable materials, oxygen and nitrous, which preferable we should avoid in laser surgery. Oxidant source is there. The laser itself is an ignition source. Preferably, it's always good to use air along with oxygen. If you have helium, it makes a lot of sense. The FiO2 has to be maintained to minimum about below 40 degrees to prevent airway fires. So using special laser tubes for covering the endotracheal tube is one thing which I would like to discuss. And of course, if you are really worried about the airway fire, you can avoid intubation and use the techniques that I just previously discussed. I use intermittent apnea techniques. PVC tubes, the red rubber tubes were used a long way in the previous years. Even the silicone rubbers have been used, but metal tubes have made laser surgery very safe. They are combustion resistant, kink resistant. We have to use very small sizes because we're using the airway along with the surgeon. The tubes are usually thick walled. They have flammable cuffs. They may transfer heat. They may usually reflect the laser, so there is not a problem. Only thing is inserting can be a little cumbersome because they are not very rigid. In case you are using the old endotracheal tubes, it makes sense to apply some benzoin, and there are metallized foil tapings available, by which you cover the whole tube, especially in the intraoral area where the laser can hit the tube. It is very important to cover the tube and provide safe anesthesia. The disadvantages of wrapping are the cuff is not protected. The thickness of the tube increases by around 2 mm. It is not FDA approved, and it may reflect the laser onto non-targeted tissues, such as the intraoral tissues. And there may be rough edges, so there can be some mucosal damage. And it limits the surgical access. The metallic tubes, Norton, were used at one time, but today we have the Bivona foam cuff tube, the Zomed laser shield, the Mallinckrodt laser flex ATAT stainless steel spiral wound tube with 2 PVC cuffs, which is what we are using every day today. The Norton tubes, I feel I will not discuss much because they are not used today. These tubes, they have self-inflating cuffs of polyurethane foams at the distal end. It retains the shape when ruptured, but deflating and removal can be a problem. The Zomed laser shield has been used for CO2 and KTP. the cuff contains methylene blue crystals. So in case of a damage, you immediately come to know about it. We have used these Merosil foam tubes, which is made of white soft rubber. It has a double cuff at the distal end, non-clinking. Only thing, the cost is a big deterrent. I mean, because it's very expensive, and so we could use it only for one patient, and then we stopped using this because of the cost. Yeah, being a private practitioner, cost is an important problem in managing cases every day. The benign dot laser flex tubes, I feel, are wonderful tools which have made laser surgery quite safe. They're basically stainless steel with smooth plastic surface and matte finish. There are two large cuffs available at distally. We are supposed to fill the cuff with methylene blue stained saline. So in case your laser beam hits the cuff also, we immediately come to know about it. The idea to add methylene blue is in case your laser beam just hit one of the cuffs. The saline acts as it counteracts the laser beam fire if at all there is. And in case one cuff is struck, still there is the other cuff which takes care of the airway, and there is the burst cuff serves like a built-in fire extinguisher. So that's why it's always good to inflate the cuffs with saline along with some methylene blue. So in case if the cuff gets ruptured, you come to know immediately. As I mentioned, water is a good fire retardant. So along with being a heat sink. So wherever you're using CO2 laser, use all your swabs, all your fabrics should be wet. Use wet drapes to cover the patient's chest and patient's hair or even the patient's eyes. A 50 cc syringe is always to be kept ready when you are using ETCO2 laser. Always be accessible to the nearest source of cold water and fire extinguisher. As I've already discussed, prefer air and use low FiO2. Unfortunately, if you do have an airway fire, there are various protocols. First thing is remove the source of fire, that is the laser. Stop ventilating, disconnect the circuit, extubate the patient. Extinguish the fire in a bucket of water, which must be kept ready wherever you have high-end surgeries. Ventilate the patient on mask with 100% oxygen. Continue IV anesthesia. Do a direct laryngoscopy and rigid bronchoscopy to confirm the extent of damage and debris, if anything, can be sucked out immediately. If surgery is still to be continued, re-intubate to assess the damage. A blowtorch fire may need a distal fiber optic bronchoscopy and lavage. Severe damage may lead to a low tracheostomy. Access the oropharynx and face. Get a X-ray chest and post-op to confirm if the damage, if at all, if there is a pneumothorax. Steroids definitely on table help us. Always remember to extract, eliminate, and extinguish the 3 E's, the first 3 E's. That is, you put out the fire or flood the field with saline, remove the energy source, as I said, remove the oxidant source, so disconnect the circuit, stop ventilation and gases, remove the blowtorch fuel source and extubate and remove the burning fragments. Then evaluate the patient, review the airway, oxygenate, review the damage done, chest X-ray if required, establish the airway, re-intubate. If you find that the damage has been huge, it makes sense to ventilate the patient post-operatively. And at least slow tracheostomy definitely helps. Admit the patient in ICU under observation, control the ventilation, hydrosteroids will help. Gas air embolism, mainly in distal larynx, I won't discuss much about it. There can be inappropriate energy transfer, so we have to be careful. I've already discussed all these things to be comfortable. Use water as much as possible and see that your drapes are wet. And I feel this is how we do laser surgery. You should be aware of all this one, the paraphernalia that are involved. This is just Dr. Meenakshi may like this joke. There is a case reported where the patient farted while undergoing a laser surgery and set herself on fire. This was a rectal surgery, but just to lighten the mood of because it's a very serious discussion, I thought I just added this slide. Next in line is going to be robotic laser surgery. I found this slide somewhere on the net, and believe me, this is what we maybe have to undergo sometime in the future. And just imagine this, you can see all the things that are there in the patient's mouth for robotic surgery. Some surgeries recordings I do have. I'll just play them for because everyone is not exposed to this type of surgeries. You can see the blue colored pledget which is there at the. This is a patient of vocal cord nodules which we were doing. After the intubation with the maling dot tube, we have inflated both the cuffs with methylene blue. Also, a methylene blue stained cotton pledget, which is totally moist, is put across the cords. You can see the laser beam striking the nodules, and how beautifully the each nodule is being burnt or laserized. If you can see the slit, this is a slit which the surgeon has taken because he wanted to just burn out the nodules. So the ATCO2 laser is, you cannot see the beam. The helium beam is and focusing on the target, and the CO2 is in tandem with the beam. So this is how you hit the beam and laserize it. And at the end of the surgery, this is what you have. The whole, you can see all the tissue has been removed and burnt out, and with zero blood loss, with zero edema in the surrounding tissue. And it's a beautiful surgery, the best way this type of surgery should be done. Coming to a CA vocal cord, just to show you how the surgeon has to plan. This was the T1 lesion. So if you can see the beam, this surgery was done with the beam being cut. You can see the laser beam. You can just see the light. You can see the cut being taken. This surgery we had done in two phases. So it was quite a huge tumor. You can see the beam. You can see how beautifully the laser is cutting the tissue. And this is how the tissue has been removed. And the same way we have done for the other part of the malignancy. This is a valvular cyst. This is quite an old. This was the initial days of surgery when we were doing the valvular cyst. This was a huge cyst. I mean, I would just like to. Giving anesthesia to and intubating this patient also was quite a difficult thing. This was an old laser which we had used. Now we have the luminous laser which we are using. This Chinese-made lasers used to leave a lot of scarring. You can appreciate the scarring which is there on the. This is how the tumor has been removed, cyst, and I mean, this is we don't use this machine anymore now, but this was the only recording I had of this. This staphylomatous we have already seen. I'll go to the next. This is a laryngeal web, which is again beautifully excised using the. You can see the laser beam on the red colored beam hitting this one, the laryngeal web, and how the laser is beautifully cutting the web. And take a little front. You can see the blue pledget, which is always there for all surgeries. You can see the surgeon splitting the vocal cord to see whether the web has totally been taken care of or not. It had not been done. So he again applied the laser beam on it, and using the CO2 laser, he cut the whole tumor. This was an intraretinoid lipoma. This is quite a huge video, so I feel I'll just show the lipoma to you. You can imagine doing this type of surgeries under laser. It's laser anesthesia is very exciting and very challenging for us anesthesiologists, especially. So right from intubation, maintaining the blood pressure, maintaining balanced anesthesia is very challenging and difficult. I thank you all for your patient listening. Again, warm greetings from ISA Nashik. If ever in Nashik, please do visit this ISA Square. And laser anesthesia, as we want to be very safe anesthesia, safe labs is our motto. So laser anesthesia should be very safe and it's very useful. It's wonderful for the patient. So really, I really wish that more and more laser surgeries come up in the country, and the patients do benefit. Thanks for a patient listening. Questions and discussions are most welcome. I'm sure Dr. Jerry will have a lot of things to discuss, but I'm sure even he does this type of surgeries very often. Thank you. Thanks a lot.
Thank you, sir, for that wonderful coverage of the topic. I think there was a question from one of the I think participants. I think it is on tubeless surgery.
Sir,
I just demonstrated that. What is tubeless anesthesia?
Sir, the question is, what are all the surgeries performed under tubeless method? Just like a tubeless tire, he has asked a general question. See the question?
Yeah.
Ah.
Dr. Muthukkottai, yes. What are the
Ah.
common surgery we do with tubeless anesthesia? Basically, as I said, for very small laser surgeries, you can do tubeless anesthesia with the patient breathing spontaneously, but it's not very comfortable for the surgeon because the larynx is moving a bit. And secondly, where if the tumor, like papillomatosis, the video that I demonstrated, there were a lot of suprapharyngeal papillomatosis we could remove with the tube in situ. But the subglottic papillomatosis, we had to remove the tube and continue giving the patient on total intravenous anesthesia. So that's what tubeless anesthesia is all about. And these are the main indications that I have been using tubeless anesthesia.
So is there any role for Thrive? I think Thrive has been used by many people.
Yes,
Yeah.
sir. I mentioned about Thrive. HFV can be done in a big. Unfortunately, I still haven't got a chance to use it. But definitely it can be used, especially post-COVID, because I've come across some surgeons who mentioned to me that even for 20 minutes, they just continued operating on Thrive without giving the patient any anesthesia, and just TIVA was continued. And the patient's oxygenation was well maintained. Unfortunately, I have no personal experience about it.
What they say is that it might be possible to keep the patient immobile for up to 20 minutes. The only problem is some of these patients become hypoxemic at the end. You may have to tube them at that point.
Yeah.
And most of them will develop hypercarbia also. So those are the two reasons why you may have to.
CO2 retention is going to be there.
But the good thing is the surgeon will get a long period during which he can instrument and then do so. All right. So, any more questions?
Sir,
There's one more question. TIVA for apnea technique. What drugs you give, sir?
That is for you, sir.
I feel there are wonderful anesthesia drugs which have come up. I use a lot of Dexmed, a lot of ketamine, a lot of propofol in combination of all three. Ketofol or Ketadex are two favorite drugs of mine for TIVA.
Sir, for Dr. Revathy, there is a question, Dr. Revathy.
Sir.
What is the muscle relaxant for post-tonsillectomy bleeding? Dr. Satyanarayan has asked.
For intubation, we use succinylcholine, and for maintenance, we use either atracurium or cisatracurium.
He has asked whether succinylcholine and racronium is okay as per the speaker's advice.
Yes.
The racronium, accepting. You were using what drugs you were using?
Succinylcholine.
Huh?
Succinylcholine, sir.
Madam, I want to inform only one thing as a feedback. See, one of your slide says intubate with a coughed endotracheal tube. Not cuffed, madam, coughed.
Oh, sorry, sir.
See, again, you are blank. It is mentioned as CO. No, that is the reason you are taking it as cuffed. But your spelling says COUGHED. It is a typical cough. It reminds one of my professor taught me about bovine cough. It is a cattle's cough, na bovine cough. So he asked, you know how a cough will cow?
Sorry, sir. But it wasn't a mistake.
He asked, you know how a cough will cow? So you have put up that thing. See, he has asked there. Now several questions have come. When methylene blue is used, if there is a cough leak, how can we prevent it, sir?
See, with the malign tubes, you are having two cuffs. We fill both the cuffs with methylene blue. If unfortunately your laser beam hits, and there is going to be one of my slides had a photo of how the methylene blue with the water saline comes out into the airway. So we cannot prevent it. I mean, if it leaks, it leaks. But at least the moment a surgeon sees something blue, he knows that there is a cuff leak and we have to be aware of it, that one of the cuffs has leaked. So there is no way we can prevent it. It's a surgical problem.
So muscle relaxant given why?
For what?
I think it's because, is it for me?
No, it is generally then the Dr.Arul Modi, but it was not fixed. That muscle relaxant given why means I don't know. That is, it is out of syllabus.
This question is like, can we do inhalation anesthesia with spontaneous ventilation? in a post-tonsillectomy patient without muscle relaxant? Is that the question?
Probably, I feel what he wants to say is when we are giving the patient apneic and HFV is continued, can you give muscle relaxant? Yes, that is what the whole idea is. If you can have immobile larynx where the surgeon can easily operate, you give the patient a relaxant, continue HFV, oxygenation continues. As even Dr. Jari rightfully said that there can be some carbon dioxide accumulation. So after the surgeon is done his procedure, again reintubate, ventilate the patient, wash out the carbon dioxide, and then only after that extubate the patient. So definitely you can give muscle relaxant.
Another question from Dr. Muthukumar Rajagopalan. Can inhalation anesthesia be provided? What percentage of oxygen should be used? Whether it is for laser or post-tonsillectomy bleeding, I don't know. But anyway,
Laser, maybe for laser, sir.
Moderator can also answer that question.
Okay. Yeah. You know what? See, when you're using a tube, you can always go down on the FiO2. It doesn't matter. You can go up to the lowest level, 30%, because you have a secure tube which will take care of it. Now, when you're using a tubeless surgery and you're using a Thrive, the technique is basically where you use very high percentage of oxygen. You don't generally lower it much because then the patient will become hypoxemic very fast. I mean, what they're saying is that if there's no tube which can act as a fuel, for example, if it's a PVC tube or something, it can act as a fuel. No fuel is there. Okay, you have a source of fire, you have an oxidizer, but there's nothing to burn there. So you don't have to worry too much about it. And they've done some studies and they've made small numbers, some 10, 20 case series, in which they have mentioned that it is not a problem at all. Their main problem is hypoxemia and hypercarbia, for which they need to put a tube. That's it.
Just to add to all that, it is said that if you can keep the FiO2 below 40, then it makes a lot of sense to, it has been found that, of course, patients should not get hypoxic, no doubt about that. You can continue air with oxygen with FiO2 of 35 to 40 for laser surgeries, especially when you are actually on the larynx. The surgery is on the larynx. You can definitely get away by maintaining a low oxygen for laser surgeries.
So moderator sir, we are precisely on time, 7:30. So thank you. You can have your wind up remarks.
Okay, thank you very much, all speakers. Starting with Arul, Pragasam. I think there was some interruption between, and I believe he was not able to complete his talk because of some issues. But you did cover all the innovation and everything properly. Well, we could have maybe spoken about the various, maybe we have had some video of the palsies, the complete palsy, the incomplete palsy, unilateral. It could have made presentation nice. So thank you, Arul Pragasam.
Thank you, sir.
Yeah. Dr. Revathy, you made a complete and wonderful presentation of the tonsillectomy bleed, and you covered all the aspects of it. And thank you very much for that.
Thank you, sir.
And Pankaj, sir, I don't need to say how well you spoke, how well you covered the topic. It's you're a master in this field, and it was, in fact, I also learned a lot from this talk. Thank you very much, all speakers. And thank you, Dr. Meenakshi, for that invitation. And thank you very much.
Sir, thank you very much, sir. Personally, I thank all the 4 speakers. But to offer the vote of thanks, I request our treasurer, Dr. Hema. Dr. Hema, unmute yourself.
Good evening, everyone. I thank everyone for your participation in the episode of Anesthetic Management in the ENT surgeries. I thank for all the participants. I thank our academic chairman, Dr. Meenakshi Sundaram sir, for guiding us through this webinar series. I thank Dr. Arul Pragasam, postgraduate, Government Kanyakumari Medical College, Nagarkoil, Thank you for your presentation on innervation on larynx. I thank Dr. Revathy, consultant anesthesiologist, Dr. Naushad ENT Hospital and Research Center, Cochin, Kerala, on the topic on anesthesia for tonsillectomy bleeding. Thank you, madam. I thank you. I thank Dr. Pankaj Ramakrishna Gupta, sir, General Council Member, ISA National. Thank you, sir. Thank you for the wonderful presentation on anesthesia on carbon dioxide laser surgeries, and thank you for the photographs you have given us. I thank our moderator, Dr. Jerry Paul, sir, Professor of Anesthesiology, Amrita Institute of Medical Sciences, Kochi, Kerala. I thank all the postgraduates, consultants. Thank you for continuous participation. Thank you all. Thank you. Good evening.
Thank you.
Before I hand over the session to Clarinet for their concluding remarks, I request all the faculty and the people who are attending. Puthukkottai ISA is constantly striving to reach a targeted audience of 1,000. So we have reached 933 maximum, and we want to reach 1,000. So I request you to forward the flyers to your group so that we will reach that target of 1,000. Thank you. Clarinet for your concluding remarks. Dr. Shreyasi. So I think we can conclude. We will leave. Thank you very much, sir.
Thank you. Thank you, sir.
Thank you.
Thanks for a wonderful.
Thank you.
Thank you so much, everyone, for giving us the opportunity to host the session. Good night.